So everybody stretch for a moment. There we go. Good. Good morning, everyone. Sorry about that. Just, I'm an old guy, so, we should be using slides, not computers. Well, first of all, I want to thank Roberta for the introduction and the committee, the organizing committee for IPOKRaTES, for certainly inviting us to this absolutely beautiful city. I've been touring Italy for the last 2 weeks with my family for the first time, and I have no idea why Roberta moved, but it is just a fabulous, fabulous country, and it's been an enjoyable time here, so it's been a pleasure of mine. Thank you very much. The first talk is, as we said, it was going to be on pathophysiology of hypoxic-ischemic brain injury, and I'll try and sort of integrate a little bit about what happens clinically with what we do with what's being done in the lab at a pretty high level. Things are becoming increasingly complicated, especially over the last 10 years in terms of what our knowledge is about basic mechanisms. And I would dare anybody to completely understand it. Certainly I don't. So this is, please feel free to interrupt and ask questions at any time, or to ask me to slow down if I'm going too fast, or certainly ask any questions that you like. And I'll start by, I don't have any disclosures in terms of financial that we're going to present, but I will say that this is perhaps the most important slide. So if you want to get a very, very in-depth overview of some of the work that's been done in the last decade to 20 years in terms of how the brain works and how it responds to injury, really, most of the credit, or a lot of the credit, goes to Joe Volpe, who everybody knows is the king of neonatal neurology and basic mechanisms. And he's recently published a couple of very nice papers in Lancet Neurology and International Journal of Developmental Neuroscience. Stephen Bax has really outlined white cell damage, or oligodendroglial damage. And if you just PubMed him or Google him, you will find a host of review papers. Bob Vanucci has done the instrumental work in the early days, and someone who I trained with on the model development that's being used worldwide, and I would be remiss in not including him in that group of individuals. And Michael Johnson has got a really nice overview in Lancet Neurology as well. And I put this up first because if you fall asleep now, at least you can go back to these and you'll be able to review things much better than I'm able to present them. So thank you. So what we'll try and do is I'll try and define a little bit what we mean by perinatal brain injury, because I think that's confusing at times. What's going on in terms of the epidemiology, some patterns of brain injury, a high-level view of what some of the mechanisms are, and then question how we can understand these mechanisms that will then lead to hopefully some therapeutic interventions, which is not entirely clear-cut. So to begin with, when we use the term perinatal, and pediatric neurologists and pediatricians and neonatologists, we all believe we know this term, but there's actually a real definition for it. It doesn't really just mean around the time of birth or at the time of birth, which I think many people sort of understand it to be. It really is defined by 5 months before the time of birth, so really the last trimester plus, or the last half of pregnancy, to all the way to a month after the time the baby is really born. Or, according to the World Health Organization, a child who is at least 500 grams, or an infant who's at least 500 grams, and it ends 7 days after birth. So it's really a very wide range, a very broad period of time, and a broad period of development. And if you can imagine this is how the brain grows over that period of time, you can recognize these are just these are MR images of the brain all the way from 24 weeks gestation to approximately 40 weeks gestation. So these are MRIs during the last trimester. And the volume of the brain grows almost double, but the overall surface area of the brain dramatically increases because, of course, of all the folding and the development of gyri and sulcation. And during this period of time is when injury, or so-called perinatal brain injury, tends to occur. And it's a time of very rapid growth, very rapid involution. And you can imagine that something growing that fast is really a moving target for injury. And that tends to be why we do see a broad spectrum of perinatal brain injury, all the way from hypoxic-ischemic encephalopathy, trauma, intraventricular hemorrhage, PVL, infections, toxins, metabolic, and genetic, all of which contribute to perinatal brain injury, and oftentimes symptomatically can look the same at the time the baby is born. And it's, of course, up to us and the neonatologist to try and determine why that baby is ill and how to diagnose that, if there's any treatment, and what the overall outcome can be. And we're challenged with the task, and well, mainly the neonatologists are challenged with the task of trying to do that all within the first few days of life and express to the parents what their child is going to look like when they're a teenager. Certainly I'm faced with that challenge on a sort of daily basis at work, and I know Linda is, and most of us probably are. And it's a daunting challenge and a bit impossible, if one wants to put it that way, to be exact. Today I'm going to focus mainly on hypoxic-ischemic encephalopathy and periventricular leukomalacia, but all of these really encompass perinatal brain injury. And you can't talk about perinatal brain injury without also talking about cerebral palsy, because that really has been the sine qua non outcome parameter of how we determine what happens to these children. We tend to use cerebral palsy as what we mean by outcome. And that has been how studies have been done, measuring cerebral palsy as an outcome from the newborn. It tends to be recognized as a motor disorder, but increasingly I think we're recognizing that it's really much more than that. And certainly I've always believed that, and we all know that when we see these children in the developmental period, that it's not just a motor outcome, but it's much, much more than that. So if we go by the consensus statement or the definition of cerebral palsy that was published in Developmental Medicine and Child Neurology in about 2007, they define it as a group of permanent disorders of development of movement and posture. But importantly, they include in the developing fetus or infant accompanied by disturbances of sensation, perception, cognition, communication, and behavior. And that's very, very important. And it's important because we are also now recognizing that there are many children who have a developmental outcome that actually doesn't include a motor incapacity, but rather is exclusively or predominantly a developmental disability in the area of cognition and behavior, as opposed to simply a motor dysfunction. And that sort of is beginning to sort of evolve at the crux of what we're trying to look at as well. So if we use cerebral palsy as an outcome parameter, and I believe that's still largely the case, it really hasn't changed over time. In fact, it's still quoted in the literature, and I don't believe this has changed, about 2 per 1,000 live births. The cost, there's been some excellent work out of the United States and out of the United Kingdom. They've shown lifetime cost for children with cerebral palsy is about 1.5 million, and it's probably far more than that because it doesn't really include lost labor, effect on families, divorce, et cetera, et cetera. So the expense to society is really massive. The investment in research into cerebral palsy, I would venture to say, is infinitesimally small by comparison, certainly in North America, and I suspect it's not much different in Europe as well. And so I think we need to actually advocate a little bit for that. So that's my little plug to advocate for increasing research and looking into cerebral palsy. In fact, when we look at what's been happening over time and the increase in the number of kids who are premature, who are born prematurely, and who are surviving, that number is increasing. So in the early days when premature survival was increasing, this number was actually much, much larger. It's actually done a bit of a sigmoid curve and it's gone up and now is coming down a bit, but still the risk of cerebral palsy is 10 times as high in the premature baby as it is in term infant, which is really dramatically increased. Now, I suspect this number will come down, but nonetheless, it's certainly contributing to why the overall numbers for cerebral palsy are not decreasing, and in fact may be increasing a little bit, and emphasizes why we need to look at this more carefully. So what causes a perinatal brain injury, and what causes that continuum? Well, we can see this is a great slide by Badawa more than 10 years ago in 1998, and when they looked at both the antepartum and the interpartum causes of cerebral palsy. And it goes along with what Karen Nelson published even way back in the 80s. I think if we look through the literature enough, we find out that actually a lot of work has been done already. We just have to interpret the data a little bit differently. But nonetheless, what we can see here is that despite the fact that lawyers like to say that most of the birth injury happens around the time of birth and we like to blame the obstetricians, in fact that's not likely to be the case. It's more likely that at least 80%, if not more, babies are injured probably before the time of birth and certainly in prematurity during the time that they are growing, and that it may not be just a simple single insult or a single silver bullet that causes the injury, but a continuum of injury that really sets up the baby for ongoing challenges, especially during prematurity, such as infections, repetitive hypoxia or bradycardia, etc., and seizures that contribute to the injury that may be ongoing. So again, another indication that, number one, when we're looking at these babies, we're often seeing injuries that occur prior to the time of birth. In the premature baby, risk factors that continue through the time of growth, and really an ongoing moving target that we have to be aware of and continue looking at. So what is that continuum of injury? Well, in very broad terms, it extends all the way from, as we know, white matter injury or so-called periventricular leukomalacia. And these are just MRI scans and a CT that depict the various kinds of injury that we see in newborn infants. Oops, whoa, jumped a bit there. Periventricular leukomalacia in the premature infant or white matter injury. We can get selective neuronal necrosis along that entire continuum. We can get broader injuries such as status marmoratus or injury to the basal ganglia in an acute insult or a sentinel insult at the time of birth. And we can certainly get neonatal stroke that we're seeing, I wouldn't say increasingly commonly, but identifying more than we have in the past. And those things, if we look at them in the newborn, in the fetal brain, look like this. If it's severe and causes cystic encephalomalacia, and all of you I know have seen images like this. And it tends to interrupt the fibers that descend from the cortical region down into the cortical spinal tract at various levels, involving either the legs or the arms, and including the face, depending how extensive it is, which leads to children to have either spastic quadriplegia, spastic diplegia, or hemiplegias that occur under circumstances where there is a stroke or what we would refer to as a porencephalic cyst, or a presumed perinatal stroke in the premature infant. So there's really a host of injuries that occur during that evolution or during that last trimester that all of us are faced with. And if we pile up all the other things I spoke about, like bradycardia and apnea, sepsis, and seizures on top of those things, we really have a very complex, confusing, ongoing type of injury that I think we need to be very cognizant of. They're not just individual things that occur, but they're additive in nature and probably progressive in nature as well. And so even the minor things that we can do, and that I'll talk a little bit about, I think, tomorrow, in terms of the simple things that we can do and that you all know about, it's not going to be rocket science, are very important, I think, to the overall outcome of these newborn babies. Okay, so this is some nice work done by Mike Chevelle in Canada. I have to put in a little bit of Canadian research, because I noticed IPOKRaTES hasn't been in Canada, so we got to change that somehow. Where we've developed a registry in coordination with a large group called NeuroDevNet that I'm part of. And as part of that registry, we're trying to define what cerebral palsy looks like in Canada. And so these are some of our early data. And what we can see is that the vast majority of cerebral palsy, about 87%, are within the spastic group, either quadriplegic, a third, hemiplegic, which is really neonatal stroke, a third, and about a quarter of them in spastic diplegia, with less being due to those basal ganglia or deep gray matter insults due to sentinel events in dyskinetic or ataxic hypotonic cerebral palsy. So the vast majority of kids really do that. And as I said, those core morbidities of cognition and behavioral abnormalities are seen in at least half of them. And personally, I feel that that's likely quite an underestimate, because oftentimes kids who are coming to the hospital, well, they'll be registered, if they're just having behavioral abnormalities and no evidence of so-called motor cerebral palsy, they may not come through our doors. And so they're dealt with in the community, and I think often overlooked or falling through the cracks. So I suspect this number of 45 is really at the low end of what is really in the community. So just to highlight again that what we do know now, and this is Karen Nelson's old paper sort of talking about the fact that much of what predisposes to cerebral palsy probably happens before the time of birth, but to also emphasize, this is a nice little review by Stephen Miller, the fact that does cerebral palsy, or do children who have impairment as a result of a perinatal brain injury need to have cerebral palsy? And I think the answer to that we're all recognizing is no, and that many of them can just have developmental disabilities or grow out of their motor component early on in infancy and wind up with challenges in school, behavioral difficulties, etc. And it may well be due to a perinatal brain insult that simply was not identified prior to the time of birth or around the time of birth. Okay, so perinatal asphyxia clearly, and perinatal brain injury clearly is impacted by gestational age, when during that last trimester the insult may have occurred, and whether or not it's actually ongoing through the time. What the underlying etiology is it hypoxia-ischemia? Is it sepsis? Is it trauma? Is it an intraventricular hemorrhage? And how long that injury has actually lasted, or what the duration is. But despite some of these variables, there's a common denominator with respect to the cycle events at the cellular level that results in what we actually see clinically. Oops. So many of us have seen this slide. I'll just stop, and I see most of you are still awake, so that's actually good. Does anybody have any questions at all? At this point, no? You probably know all of this. I'm not going to tell you anything brilliant. Okay, excellent. So this is an old slide, which I actually love, by Wigglesworth from one of his old papers. You can start to tell how old I am, which is not a good thing. But he infused a fetal brain years ago with a red dye to show the development of the arteries in the newborn brain. And it very nicely depicts at 24 weeks of age. You can see that there's really a paucity of blood flow, particularly in this area here. Sorry, just to orient you, this is the surface of the cortex. Down here is the ventricle. And you can see at 24 weeks, all the way up to 34 weeks, there's a paucity of blood flow in between the arteries and around the ventricular region that would suggest that if the blood flow were to decrease, or if oxygen were to diminish, or an infection were to interrupt that, or if there were pulsatile blood pressures during the course of time, that the most sensitive area for injury from a topographical perspective, not from a cellular perspective at this point, but just from a topographical perspective, would be the periventricular region and watershed regions in the cortex. As the baby gets older, what happens is that these blood vessels actually join up and anastomose, as you can see here to some extent. And so they are no longer so-called end arteries, and they become confluent. And so a drop in blood pressure does not pose as much of a risk to that area anymore as it did early on in life. And what happens is that the surface arteries between the anterior and the middle and the posterior cerebral artery, those become end arteries. So in other words, they end where they meet. And so if the blood pressure drops in a term baby, then the areas of greatest risk are the so-called watershed regions between the major vessels. So from a topographical perspective, I believe this is what happens is that in the newborn, in the premature infant between 24 and roughly 32 weeks of age, the most sensitive areas for injury, or most vulnerable areas, are the periventricular regions that are the watershed regions. And then as the child grows, it becomes the end arteries between the major anterior, middle, and posterior cerebral vessels. And this slide nicely shows that. So then what else contributes to the fact that the white matter injury, or the periventricular region, is so sensitive to injury? And Stephen Bach has shown this really quite eloquently in a whole host of experiments that he's done at the cellular level to show that the developing oligodendroglia, or the cell that makes the white matter in the brain, or the myelin in the brain, is exquisitely sensitive to injury around the time that it's forming, or the pre-oligodendroglial stage. So this is a fairly immature oligodendrocyte, around 24 to 32 weeks or so. It's pre-myelinating. The brain's not really well myelinated. And that cell itself is present between 24 and 32 weeks of age, becoming more mature as the baby matures, and it tends to be exquisitely sensitive to injury. And I'll talk a little bit more about that as we go on. Underlying all of these, though, are some really very basic concepts that I want to sort of go over with you a bit. And this slide is an old one that I made up quite a long time ago. It really hasn't changed at all, because the basic mechanisms of injury, whether it's hypoxia-ischemia, whether it's IVH, and even to some extent sepsis, all wind up with components, if not all of this. And the first thing that generally happens is, especially when there's a lack of nutrition to the brain or substrate, what we see is a drop in energy. And that's at the mitochondrial level. ATP, if most of you remember your med school, is what is the fuel for the cell, and it's made by oxygen and glucose, and it requires the mitochondria, and it requires oxygen to make its maximum amount of ATP. And that drops off relatively fast. Now, this is just a slide showing the rapidity of drop-off in one of our models of hypoxic-ischemia in the newborn rat. It occurs very, very quickly within the first 20 minutes or so, down to about 20% or so. And we looked at this more closely in our lab in vivo a number of years ago, and we looked at the release of lactate dehydrogenase in the cell and when that occurs. And this is very consistent among a number of different papers. We looked at astrocytes in culture, and then we deprived them of oxygen and glucose. And what happened was they maintained their ATP levels, or their cell structure, actually pretty well, until they got down to about 20 to 25% of the amount of ATP. And this is consistent with other work. And what it says to us, really, is that the cell is really pretty hardy, but it uses the vast majority of energy to just maintain the walls, to maintain the membrane structure of the cell and not allow leakage of sodium and chloride and potassium, requires between 60 and 80% of the energy in the furnace. So if you imagine your house, well, that's probably not a good analogy, but basically it's the walls of a house that it's maintaining. And most of the energy of that furnace is being used to maintain the walls. Once it gets down to about 75 or down to about 25% of its ATP, the walls collapse and the cell dies. And that's really at the basis of a lot of what we see. So mitochondria, in the middle here, play a huge role in how the cell is functioning, and in the whole cycle of events that then leads to damage later on. And so what we can see here in the middle, is the mitochondria. I can't see my slide very well. And what happens is that it loses its energy, and it starts to release a whole bunch of nasty substances. And there are slides, and I sort of played with showing you slides of the various pathways that are now recognized within the breakdown of the cell and the cell membranes and the production of reaction oxygen species, etc. And to be quite frank, it boggles the mind. There are literally thousands of different proteins and components to this whole cell breakdown and cell maintenance aspect. And as I said early on, I belie anybody to completely understand it, because it's so hugely complex. And I think that also is at the crux of why it's so hard to treat this, because once we have this structure breaking down, it's a bit like all hell breaking loose. Could I say that? and it's very difficult then to get things back in shape. But once the mitochondria break down, we get the release of energy depletion, the allowance of glutamate, which is a neurotoxin, to enter into the cell, calcium to be released within the nucleus, and then a perpetuation of events that I'll just sort of move on and show you in a moment. Can I move that? Okay, it's not moving. Let's go. Is there a way I can get this? Ah, there, okay. So what happens, and these again are slides, what's happened once that energy fails, what we can see here is that there's a massive increase in the glutamate that occurs within the cell. Now, glutamate is a normal component for the development of the brain. So it's normally there, and it's there in reasonable quantities. In fact, it's there in quite high quantities because the brain is rapidly developing. And it's in much higher quantities than it is in the adult brain. What happens, though, when you lose energy is the ability of the brain to reuptake that glutamate is now lost. And so it stays within the interstitial space, within the extracellular space, and creates and becomes toxic to the brain. That leads to so-called calcium accumulation within the brain, and that perpetuates an inflammatory response and free radical production and inflammation, which can occur for a very long period of time. This is a slide that was done, I believe, by Francis Northingen, and they looked at a hypoxic-ischemic injury, and then they looked at the inflammatory response throughout the course of the next series of days and weeks. And you can see here that even at a month of age in this particular model, there is still an inflammatory response that's going on. And just in the last month or two, actually, there was a publication by Winterhall that looked at the same model and looked at the inflammatory response and how that occurs over time. And in their findings, they actually found that this inflammatory response occurs for an extremely long period of time, not just hours or days or weeks, but it continued to occur all the way out to 3 to 7 months. So there is a huge cycle of events that occurs very early on at the time of injury and perpetuates. It continues to go on for hours and days, and this perpetuates the cycle of production of calcium toxicity, free radical production, and inflammation. Now, what that says to us is that, in fact, there's a host of events that are occurring and that injury is continuing to occur for a very long period of time, which is bad news because it's continuing to occur. The good news is that perhaps we actually have a long period of time by which to intervene, and even perhaps much longer than we originally thought, at least according to this information. And that tells us that we can do subtle things during this time that can perhaps reduce the degree of deficit that we're seeing. So now we know that that if you interrupt blood flow or interrupt substrate that's going to the brain during that last trimester or any time, but certainly during that last trimester, that you're going to interfere with the furnace, that you're going to reduce the amount of energy that's being produced, and that you're not going to really be able to reaccumulate that. And that can cause a whole cycle of events that's injurious to the brain. In recent years, or recent meaning the last decade or so, we've also recognized that inflammation plays a really strong additive role. And despite the fact that there's still a bit of controversy about this, I think the brunt of the evidence suggests that inflammation, either in the form of chorioamnionitis or in the form of biochemical inflammation, or simply in the form of inflammation that's produced by the injury itself, contributes significantly to the risk for cerebral palsy and developmental injury. And recognize, too, that these studies are all measuring cerebral palsy, and when they say cerebral palsy, they're really referring to a motor deficit. So we're likely, again, underestimating those kids who may be injured without a motor deficit. So those kids who have school issues or developmental delay or behavioral issues. And in this study, that a systematic review done by Yvonne Wu in California, what they found is that kids who had clinical chorioamnionitis had almost a 3 times risk of developing cerebral palsy. those kids who just had histological chorioamnionitis had a 1.5 to 2 times risk. And as I said, I suspect that that's even an underestimate based on the fact that they were looking at kids who had pure cerebral palsy. Now, so at the basic science level, this too has been proven, both in our lab, and this is work done by Pierre Grasson, who's a much more important guy, so I thought I'd show his stuff. And what he's shown here is a nice paper where they used LPS, which is lipopolysaccharide, which is a substance from E. coli, and they injected into the brain of usually 7-day-old rats. And what they looked at was the myelin basic protein production with control, and then they looked at the amount of cytokine or inflammatory response under both circumstances. And they found that if you look on the bottom slides, that in the animals who had the LPS injected, that the amount of myelin basic protein and the amount of PLP as one of the indicators of myelin basic protein was much less. So in their animal model of chorioamnionitis or fetal inflammatory response, you can see here, this is the corpus callosum in the rat. The amount of myelin production was much less, and the amount, and the amount of inflammatory response was much greater. And what these things lead to, the loss in energy, the production or the release of glutamate, the production of an inflammatory response, the production of free radicals, is really to 2 types of cell death, so-called necrotic cell death, which happens relatively quickly, and I think you all know that, and is very mitochondrial oriented, with the loss of ATP and involution of the cell, or programmed cell death, which is a naturally occurring phenomenon in the newborn, but can be accelerated under circumstances where an injury has occurred, and may well be part of that continuum that has ongoing cell loss for those days, weeks, and months afterwards. So this is really a simplistic cartoon about what happens under circumstances where inflammation occurs. If this is inflammation, the LPS injection, it creates a cytokine response. It attaches to cell membranes through a toll-like receptor, which has been identified. It stimulates prostaglandins, which also stimulate microglia, which are at the center of things, and then create this huge cycle of events that really is ongoing and continuous. And once that happens, is really difficult to interfere with. But in addition to the mitochondria that we see, the microglia also seem to play a very important role in terms of the inflammatory response. And that is central to both an inflammation and to a hypoxia-ischemia, where they stimulate toll-like receptors on the surface of the microglia. And again, these release factors that then further stimulate an inflammatory response through cytokines, produce reaction oxygen species, release more glutamate, and ultimately injure the white cell and its surrounding structures. So what does this all mean? So if we just summarize a little bit, we know that under circumstances of ischemia or sepsis, that the circulation in the baby's brain is pressure passive, and you get a reduction into the brain. And those areas that I showed you that are in between the end arteries or the watershed areas are most predisposed. If you have infection, there's that occurs during the maternal intrauterine, and that can certainly potentiate ischemic injury. And we've also talked a little bit about the pre-oligodendrocyte, and I'll go into that just a little bit more. So the loss of cerebral circulation and the infection can certainly cause large areas of injury that we see in the brain, and cystic leukoencephalomalacia. But what causes the smaller areas of injury that we don't necessarily see on MRI, the microscopic or so-called microscopic areas of injury that Linda may talk about a little bit later on today or tomorrow, where we're really not necessarily picking them up with conventional MRI, or you have to have a significant experience to do so. And those may well be the kids that we're either missing or coming to our clinics afterwards who have developmental delay that's not cerebral palsy in nature, or the ones that have very minor degrees of cerebral palsy, or may even grow out of them in the early part of age. And that may be where injury specific to this oligodendrocyte occurs. And what's been shown, again, very nicely by Stephen Back's group, is the extreme sensitivity of the oligodendroglia to this neurotoxin that's released after energy is depleted, which is glutamate. And in this slide, what he did was he looked at glutamate-like reactivity, and in the dark is control, and post-ischemia you see the white, and here is the increase in glutamate reactivity in the post-ischemic oligodendroglia in various areas of the brain. And essentially what he showed is that in the newborn brain, in the premature infant, or in this model of a rat, is the extreme sensitivity of this particular age group and the pre-oligodendroglia to glutamate. And that coincides with the fact that the amount of glutamate receptors and the enzymes within the newborn brain, within the premature brain, are really at odds with each other. So you have very high glutamate levels in the newborn brain and the premature brain between 24 and roughly 32 weeks. You have not as high enzymes that can reduce or soak up the free radicals in the brain. And so it's a real setup for sensitivity to glutamate, the neurotoxins, and then subsequently the production of free radicals. So if that balance is offset early on in life, and particularly in this period of time when the pre-oligodendroglia are forming, you have a setup for injury. And that may well be why the oligodendrocyte is most sensitive to injury. And this is just a slide showing that after exposure to the glutamate in cell culture, this is a normal oligodendrocyte with a lot of processes going around, these cells have actually arrested in their development. So not only can they be damaged and killed by the excess glutamate and by the inflammatory response, but the ones that sort of survive have arrested development. They no longer can go on to develop their processes and form their myelin normally. Okay, so we have a very maturation-dependent factors that can result in periventricular leukomalacia. There's vulnerability of the oligodendrocyte. There's excitotoxicity that occurs and that the oligodendrocyte is much more susceptible to. And there's the concept of microglial activation, which can further enhance excitotoxicity and damage. And what does that look like clinically? I'm going to move on here. Clinically, where that happens is in the subventricular zone here. These are where those cells are forming, the oligodendrocytes are forming, and the stem cells or the subventricular zone cells are migrating outwards from this area of the brain to form neurons and to lay down their axons. And Volpe has very nicely pointed out how that can interfere with the development of the brain based on when that activity occurs. So if it's less than, if you have injury in this area of the brain where the subventricular zone is, where periventricular leukomalacia occurs, you can interfere with various aspects of development depending on the time of that injury. So at less than 20 weeks, you're really injuring it from the onset, from the very beginning of life. And so migration out to the surface of the cortex doesn't occur. Axon development down to the thalamus and the corticospinal tract doesn't occur. If it happens later on in life, you can get arrested development as the cells are, as the axons are forming downwards and into the corticospinal tract. And if it's much later on in life, then those have formed, but they'll interfere with the action of those axons producing predominantly your motor component. So it seems to suggest that the earlier on in life that this occurs, obviously the more injury that is going to occur because you're arresting the development of this entire process, as opposed to if it occurs later on in life when the axons are being formed, and perhaps it's then that you'll get mainly the motor components of what of outcome. And this is really a fabulous article that I quoted a bit earlier on, but it outlines very nicely the evolution of injury and is really quite brilliant. I'd suggest you have a look at that if you're interested. So clearly we can see an evolution of events that occurs, and I'm just going to jump over that. So what does all this look like to us? So we've seen that there's really a quagmire of events that occurs that has some degree of staging. It starts with a topographical predisposition of the brain based on vascular maturity and development in the premature brain all the way to the term. We've seen that that can evolve in different ways at different ages, from periventricular leukomalacia to stroke and cystic encephalomalacia to basal ganglia injury. We've seen that it can interfere with processes throughout the development of the brain. And yet, when we look at babies in the nursery, we're still kind of using these kind of scores to predict. And we're still seeing babies who really only show us very little in terms of clinical, of what they look like clinically. They have alterations in their level of consciousness. If they're much younger, they oftentimes are a bit more lethargic and not feeding well. They have neuromuscular abnormalities and tone control. Their reflexes may or may not be present, and they oftentimes will have seizures. And the San Francisco group uses a 6-point score looking at feeding and alertness and tone, respiratory status, reflexes, and the presence or absence of seizures. But really, all of those things that occur, sort of perinatal brain injury, turns out to be this or one of these abnormalities as a clinical component. And so, how do we really go on to predict outcome when mothers come to us and say, "What's my baby going to look like?" Oh my God, how do you really do that? And so, recent years have really been quite productive, to be quite honest. And groups in the UK, in Italy, and certainly in the Netherlands and the United States have looked at neuroimaging as one aspect. And I'm not going to go into this deeply because I know that Linda will talk to you about it. But we can use tools like magnetic resonance spectroscopy that are starting to tell us a little bit about the predictability of outcome in certainly term babies. And I don't think studies have been progressed that much in preterm infants, but that's certainly the direction we're going to have to take, looking at levels of lactate and acetyl-aspartate and creatine to tell us whether or not that area of the brain has been injured. And we can do that in specific areas of the brains like the basal ganglia. We can do it in the cortex or in those watershed areas that I referred to earlier on. And so those things are really becoming very, very important, important in terms of prognostication. We also have contributing factors, though, that make this much more complicated. And I'm going to be ending soon, so you can all take a big sigh of relief. But they include seizures that I know that Roberta will talk to you about in a minute, hypoglycemia that occurs frequently in newborn infants, thermoregulation that we've all talked about and are very aware of, hyper and hypocarbia that I'll talk about a bit tomorrow. Humidity seems to play a role, and even gender and sex play a bit of a role. And I'll just very briefly talk to you about that, because we oftentimes don't even allude to this when we're referring to outcomes or what it means. But it's become very clear that males and females, even in the newborn period, seem to respond differently. And anecdotally, I think most of us know that if we have a newborn baby, if it's a boy, we know it'll do worse. If it's a girl, we're more hopeful. Boys always seem to get the short end of the stick. But this is a bit of a study that was done back in 2005, and they injected an NMDA glutamate into, again, a cell culture, and they just looked at the amount of neuronal death, and not surprisingly, it was worse in males than it was in females, and their response to a inhibitor of that was better in the males than in the females, so it blocked that. And and then when they added estrogen, it reversed it. So estrogen actually made a big difference. It made the males better. We've seen that in our own lab, where we've looked at outcome of the Vannucci model in an enriched environment, and we see that under ischemic conditions, the males do a lot worse than the females do. And when we enrich them, they do a little bit better. They come back to normal. And we've shown that also if we looked at other behaviors, such as novel object recognition. So both in the lab, in vivo and in vitro, and in behavioral studies, and there are many more to really confirm this, males seem to be doing worse than females do, and it clearly has to do with a hormonal effect. And then finally, I'll just let you know, and there's been a huge amount of work done by the Italian group here, looking at what biomarkers and personalization. And this is some work that I did a few years ago. We looked at a systematic review about what biomarkers are currently available and how we'll be able to help predict, along with neuroimaging, what the outcome might be in some of these babies. And so when we looked at individual biomarkers, the interleukins, certainly 6, S100, and IL-8, as well as lactate, seem to serve as very strong markers on a univariate analysis. And when we did multivariate analysis, the ones that turned out in serum and in the cerebral spinal fluid were IL-6 and neuron-specific enolase. And the Perone group just published, actually it's not even published yet, it's just online, a nice review on biomarkers of oxidative stress in fetal and neonatal disease, suggesting that lipid peroxidase parameters of free radical production can be used as biomarkers of injury. So we've come certainly a long, long way from what we knew about 20 years ago, and we recognize now that certainly perinatal injury occurs over a continuum, and probably is a continuum of injury over time and development. It's extremely complex in nature, affecting both white and gray matter, both in the ante and intra and probably postpartum period of time, perhaps out for weeks and months. There are major mechanisms that are involved in this, both topographic, which are likely vascular in nature, but also the intrinsic vulnerability of especially the oligodendroglia in the developing brain. And this complexity of injury for us, I think is going to require a very personalized approach to therapy, both from an age-specific perspective and perhaps from a global perspective, as opposed to trying to inhibit all of those molecules that are being released during that time. So I'm going to end there, and thank you very much for your time. And I'm certainly happy to take any questions from anybody. Yes, thanks.
I was impressed with the slide that you showed us about the inflammation continue for a period of 7 months.
Yeah.
It sounds like when it happened in the brain, in the lungs happen in the brain also. What percentage of destruction is happening on the brain during that period of time that we can sort of try to prevent? Because I think most of the therapy seems to be dedicated for the first week of life. But what happened in those 6 or 5 months later? I'm just curious.
I think that's an excellent question. I don't really